So this is the Gross Clinic, Samuel Gross. It's a very famous painting, but what I want to point out to you is this guy over here happens to be Thomas Eakins, the artist. And back, this is 150 years ago. They learned a lot, but they took notes. Let's just say to treat patients, they had minimal therapies. But just to give you a perspective, you fast forward 70 years, same place, Jefferson. And what happened here was the first heart-lung machine bypass case with Dr. Gibbon. And here's a note to Dr. DeBakey, a famous Houstonite, that basically says from Dr. DeBakey, he says, "Dear Mike, here's a picture of the first heart-lung bypass, April of 1953. That's 70 years ago. And now we fast forward to the Houston Shock Symposium 70 years more. And again, my gratitude for being here. And we're going to talk about the pathophysiologic complexity and how the model that we currently have fails. Because that's what this meeting is about, just like Igor said. Let's talk about shifting paradigms. So we can restore circulatory support, but why do we fail to improve outcomes? I mean, let's be honest. The shock teams may be improving outcomes, but I want to see randomized data one day. I do. I think the shock teams are doing great, and I'm totally a shock team, of course, Ali's here, motivator. But next, we're going to talk about the tissue. So a new paradigm, talking about how does tissue not get perfused? Well, the endothelium is hurt. Talk about the endotheliopathy. That's what SHINE is. Shock-induced endotheliopathy, and this is something I've learned from European colleagues. We just came back, several of us, from the critical care trialist meeting in DC, put together by the French. Fantastic meeting. I urge you guys to apply and go to that meeting. So, the paradigm, you've seen this. Spiraling shock after a myocardial injury, hypotension, leading to also a low SVR state with RV dysfunction. I think this is old. Sorry. Yes, that's how we treat patients, but I think we got to move forward a little more. And what I want to discuss is, so when do we initiate therapies? What do we use as guideposts? We use catecholamine necessity. If they're high catecholamine use, this is an old slide, post-cardiotomy shock by Lou Samuels, another Philadelphian, who basically showed that that you're just needing to do something when you're up to 3 pressures. You can't just go to sleep. If you have to go to sleep. But your patient's on 3 pressures, what do you do next? So now we have data that not only the number of pressures, this is data from Benham Turani from Innova, the duration of pressures. So the number of pressures, duration of pressures, what's the theme here? Catecholamines are bad. And I think they're bad because the endothelium hates them. That's a hypothesis I have. But that's what we have to do to resuscitate somebody. So cardiac power output, you see that was also a risk marker there. And what have we done with a restoration of cardiac power output? We've put in devices, and we've saved people's lives, no question. Every year, the patients we are able to support get sicker, and so we'll never know if we're doing better or not, honestly, historically. But it's the same average, right? 50% mortality. I'm not even going to go over the IMPRESS trial because those were 2 sick patients, but if you look at the registry for Impella versus the IVP Shock 2, 50% mortality. Can we do better with ECMO? Maybe more biventricular flow, more flow. Well, if you look at the German registry, contemporary analysis looking at the average. Yes, age matters. That's the right-hand panel. Age matters as far as mortality, going up to 70% in the 70-year-olds. But guess what? 50 to 70%. Even the young, 50% mortality. What is it about the 50% number? I've heard Dr. Baran speak many times, and he and I both agree. What is it about the 50% number that we're just stuck in this field? All right, so now you have someone on ECMO. Well, put them on with LV unloading mechanisms, maybe create an ASD, maybe you go ahead and unload with a Impella, and that's the paradigm now with ECPella. And how are we doing with that? Here's Pappalardo's data, around 50%, better than the 80% that didn't have the Impella on top of ECMO. And a more recent analysis showed up to 65% mortality with ECPella, okay, more recent analysis. I presented this at the Critical Care Trialist Workshop. This is work by Michael Ibrahim, a brilliant cardiac surgeon. He's a trainee of Dr. Ackers and Dr. Bermudez. And we wrote this trial, the reverse trial, which is randomizing patients on top of ECMO to Impella, yes, no. Why do we do it? We believe that early unloading would make a difference maybe in our study. And I presented just very early, just the number of patients. This is an adaptive study design. We haven't gotten to our 20. The bottom line is 2.5 years later, we still only have 19 patients. Slow enrollment, tough study. 9 patients have survived, still 50%. So what's the new paradigm? I'm going to try to go quick here, and then we can take questions at the end. This is a summary slide. 45 to 55%. Here's Dr. Carr's data, Biswajit's data, which was a very early paper. Very sick patients. They're on the right-hand side. These guys were, some of them were being actually actively resuscitated while the tandem went in. So what about this new paradigm is sticking in my mind here? What about the endothelium? And what about what causes surge? What causes these patients to puff out, look like Michelinized patients? And finally, why do we have progressive LV dysfunction even when we unload patients sometimes? And again, this whole idea of SHINE came from the critical care literature, shock-induced endotheliopathy, that you're basically dysregulating the endothelial barrier, but you're ultimately making the endothelium almost, not permanently, but for the case of this patient's life, days, really injured with capillary leakage and so forth. So in comes a paradigm to try to test this hypothesis, adrenomedullin. What is adrenomedullin? It is a potent mediator of both vasoactive at the level of the smooth muscle cell, as well as a mediator of being able to keep vascular integrity together at the level of the endothelium. So endothelium and smooth muscle cell activator. And what I want to show here is that if you measure, so it's in the intravascular space, but it's also in the interstitium. And I learned this, again, recently at the critical care trialist meeting. The depth to which the Europeans are getting into this is really impressive. So the idea is it allows you to stay, without edema in health, but with edema if you disrupt this barrier and you basically disrupt endothelium and you may have a dysregulation of the system. So you measure bio-ADM, that's the intermediate that you can measure, and all these studies in critically ill patients have shown absolutely a correlation of mortality when it's elevated. These are studies in septic shock, all having a differentiation of survivor, non-survivor. Here's a survivor, non-survivor plot. If you look at the bio-ADM above 55, remember that lactate is a great predictor early. And then some people use it late, but not after a couple days. After a couple days, you and I aren't looking at lactates. If we are, we're in trouble. But this bio-ADM at 48 hours, it's a predictor. And this is the question, why? Is it part of the disease process that we're totally missing in shock? So, again, Europeans, at least 2 steps ahead of us on this one, and I'm really proud to say that I'm glad they're doing this. This is a great trial they're going to come up with now. So, adrucizumab is a antibody that gives you a non-inhibitory action on adrenomedullin. What does it do? It basically allows you to keep the adrenomedullin inside the vascular space, so it increases it, and it decreases it in the interstitium, so you're pulling away from the vasodilatory. So you basically vasoconstrict, while you're keeping vascular integrity the same. So because I'm going to go to the end, let me just show you this quick cartoon. That's what it does. It basically gives you vascular integrity support while you're decreasing the interstitial smooth muscle cell, and so you're no longer vasodilating. Let me just say that I'm very impressed how quickly this has moved forward. I think industry's part of this. I don't know the industry component here, but I met some of the people there in DC. What I'm impressed is here's the design of the ACOST-HH trial, which is basically cardiogenic shock. You can have a lactate above 2. You can have mental status changes. You can be altered perfused peripherally. That's how you get into this trial. And of course, they have the usual, basically, exclusion criteria. This is a population in Germany now of 4 centers, including Berlin, Ulm, Mannheim, Hamburg. This is a population that now has been categorized, and Jacob, you'll remember this slide. These are basically the different SKY definitions, and basically the mortality in these differentiated groups is up to 75%. There's no exclusion for stage E. You can be in this trial. So we're going to wait for the results, but let me just summarize. So revascularization, the culprit shock study gave us really good data to say, get in, get out. Now maybe there's more people that want to look at cardiogenic shock and revascularization if you can't do a primary lesion, a PCI. Do we have anything for metabolism? No. We're still investigating that. Mechanical assist devices, trials ongoing with ECMO and randomized trials in Europe. We do have here a new paradigm, and that's endothelium injury and endotheliopathy, and the ACOST-HH trial will be out. I'm just going to give you the timeline. It'll be June of 2020. Of course, granted that COVID-19 doesn't alter this pathway, but June of 2020 will be when this trial is presented, probably at the ESC. Thank you. I want to also thank Mahir Karakas. He is the gentleman who gave me some of these slides and taught me a lot about adrenomedullin. Thank you.
Eduardo, that was a wonderful discussion, and I'll start with the discussion afterwards. You commented on vasopressors, catecholamines as being harmful. Besides the endothelial dysfunction, also there's data from the pheochromocytoma where you have this massive storm of catecholamines and people have biopsied the hearts and they have 45% incidence of fibrosis. So independently of the harm on the endothelium, catecholamines really adversely affect the myocardium, and I think that's one of the things we're going to be hearing during this session. My question for you is that although you're kind of working on the endothelium, that's very late in the process of cardiogenic shock. What are you doing at Jefferson to get people identified and treated sooner? Because that's kind of, I think, where a ton of the action is going to be. Identify them sooner, treat them, support them so they don't get into all this endothelial dysfunction problems.
So, Dr. O'Neill, I can tell you what we did at Penn for the last 10 years where I was at. I just moved this week to Jefferson, getting to know that place. Importantly, number one, the shock team establishment at Penn now is about a year and a half, maybe a year. And the timeline we set up to kind of do both AMI and non-AMI shock with Christian Bermudez, Joyce Wald, and our colleagues just put us right on time. The shock team's been activated there. I'll be honest, the first thing we did is look at our data, our ECMO data. We have data that shows that we can decannulate some of these patients, but we're still struggling to allow these patients to do well long term. We have a 30% loss in the hospital after decannulation, even in those that did not have, as it were, you're decannulating to a moratorium, to death. I don't think it's late, this endothelium pathway. Let me tell you why. I think if you look at the ACOST-HH trial, number one, they are giving this up front. This is a humanized antibody, adrucizumab, and it's working on the paradigm that you have immediate probably injury. The question is whether you may already have some injury just from a myocardial infarction because of what's happening in the coronary vasculature, and think about the congestion in the lungs, even before you start going into multi-organ failure. So these guys are going up front. In terms of device therapy, I think that's what you're getting at, we use all the devices at Penn. And at Jefferson, we have now just contracted to go to Impella 5.5 for intermediate support. But I gotta say, we can escalate very quickly for cardiogenic shock. I'm not sure, let me just finish. I'm not sure you're gonna be able to improve outcomes remarkably well.
But, the problem is that right now in America, we're stuck because a patient comes into a hospital with their blood pressure 60. The first thing they do is start one vasopressor, then they start two vasopressors, right. Then they put a balloon pump in, then maybe an Impella, and then 24 hours later you're called, and by then it's over.
You're right.
So I think that's why I'm asking you. I think all of us leaders in our own communities have to figure out ways of shifting that paradigm, or we will continue to be stuck at a 50% survival.
So let me say, Biswajit asked me to be provocative. That's my first disclosure. Marwan didn't say anything, but I'm sure he wants me to be provocative. I completely agree with you. That's why shock teams are being developed. But I'm going to predict if we do a randomized trial of a set of institutions that are shock team oriented and those that aren't, I want to see that data. I mean, I hope we can make a difference, but I'm pushing for more, I hate to say it, more medical therapy that can be in tandem with mechanical therapy to really support shock. Our patients, after 2 days on ECMO, with an Impella in, are still modeled. We've seen that all the time.
Just to comment quickly, yeah. Eddie, to the point that Bill's making, you want to be provocative? We're treating the wrong endpoints, bottom line. Of course, we have to deal with the patient in front of us whose blood pressure is in the tank, so we do what Bill just described. But the reality is, you want to be provocative, we're not addressing the global metabolic situation that's developing in the patient. Problem, we don't have a way to figure it out. We don't have a way to identify the biomarkers, the specific details. So, when we get to the next session, I'm going to kind of hint at this, that potentially down the road, looking at the patient as sort of a mosaic with AI and other things, we might be able to very quickly do that. The issue is quickly. So that's the point. We do what we do because we want to save a life based on the way we know to treat patients now, but we're really not addressing the whole global scenario. It's not just the blood pressure hemodynamic issue in a patient. That's just an initiating spark that's causing a total body scenario, and we have no way to treat that right now. And we need to start to think about that, and you're addressing that point.
Totally agree.
So, Eddie, I'm going to kind of amplify what Professor Slepian just actually said, which is that if we're going to be provocative, before you start actually identifying the endpoints, and I agree with you that in fact that's an issue, why don't we start with, although I agree what Dan said yesterday regarding clinical trials, I'm not even sure we actually know what the hell we're talking about. This is like diastolic heart failure right now. You know, I mean, we can't even decide what, you know, I mean, it's HFpEF and it was all of these things that, you know, so we don't even know what shock is or how we should define a homogeneous population. We can't even agree on what success actually looks like. So how are we going to define endpoints? So using surrogate endpoints, because, you know, a good endpoint always is death, right? We can agree on that. Probably hospitalizations as well, or whether or not you're around, you know, in a year. But the bottom line is that, in fact, despite the fact that I totally agree with what Dan said yesterday, I'm going to take another facet of that same diamond and say that I think we're more in a collection kind of descriptive, you know, phase now before we can actually get to the point of granularity of defining who it is. So talking about whether or not one shock program that is a center of excellence versus anybody else right now, I think that's why it's the Wild West right now. It's because we have no way of measuring this.
I think what you said is music to David's ear, who basically gave us a staging definition for shock and for what Ali and a lot of us are trying to do. I'm going to tell you, David, I've been thinking about this. I hope you're right. And Dr. O'Neill is a testament that early and programmatic scheduled like escalation really matters for a individual patient. The question is, we're not going to get to stage patients, I think, so smartly that you're going to say, this phenotype's going to 2CA category and we're going to do this. I mean, I really think we need biology to rule the day. That's what I think.